Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing just great. Thank you.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and our lone US COVID statistic through today, July 11th. We invite you to submit questions or topics of interest down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with our abbreviated COVID statistic, average COVID deaths per day are at 32, and in 2023, the same week, we saw 83. Dr. Murphy, a reaction to that number?
Stable. That's still about 12,000 people a year dying from COVID. This is on top of like every other disease that we have out there. However, looking at the little data that we have, since it's not a reportable disease anymore, there is a wave going on right now. New York City they count in a different way. They look at it differently. They had a 250% uptick. I myself had noticed many people calling with a positive test. They get at the pharmacy. None of this is reported. I spoke with one of the pharmacists that I was calling in some Paxlovid for, and they said they're getting a lot of requests for Paxlovid right now. That's the treatment for COVID. Mm-hmm. So it's we're having our summer wave, and we'll see what happens.
Mm-hmm. And speaking of that summer wave, has there been any big changes in the dominant COVID variant, or is it about the same?
Yeah, it's a very dynamic process. So they have these new flirt variants. It's all related to Omicron. So it started this year with JN1, and right now the most dominant one is KP3. That accounts for about 37% of all the new cases recently. The symptoms are very similar, but I think people have to keep in mind, this can be a very severe disease, even if you're healthy and young. So there's a whole mishmash of not too sick to sick and hospitalizable, how much immunity you have, either from prior vaccines and boosters, or you had COVID in the past. So you put all that together. Remember that all the immunity, no matter how many times you had COVID and no matter how many vaccines you had, declines over time. That's why, like with flu, you have to do a booster shot every year, a new shot.
Mm-hmm. And on that same topic with the boosters, the vaccine, looking forward and looking backward, I'm one of those people that when I get my COVID vaccine, I often have those short-term adverse effects, fever, chills, all that stuff. However, I understand there's been some really interesting research that just came out on this topic. Could you break it down for us?
Yeah, no, there's some interesting studies have been reported. So there's all different kinds of antibodies. So sort of the strongest ones are these neutralizing antibodies. They're more long-lasting. They're very powerful. And there was this beautiful little study reported in the Annals of Internal Medicine last month that the short-term adverse effects, like chills, feeling unwell, tiredness, ache, fever, that the more of those symptoms you had, the better the neutralizing antibody response you had. Approximately 10% per symptom. And that overall, there was especially, if you put it all together, that it's about 50% higher if you had a bunch of symptoms related, short-term symptoms. So it's just a nice report showing that it's your body fighting off the disease and creating this immunologic response.
Mm-hmm.
And
Now, because
it's
these,
probably
oh,
true also with the vaccine. You
yeah.
know, I mean, we think that, but we'll see if they do as sophisticated a study as they did in these patients.
Now, on that topic, these data were from 2021, and many of us have taken an antibody test before to see if we have antibodies or not. What makes this test different, and why might it have taken them so long?
There's no antibody test that anybody can just order for this type of thing. It's a very sophisticated, complicated kind of test to do. You can't just order an antibody test like this.
Mm-hmm.
It's really a research tool. And so don't go out and just, I need an antibody test. That is not going to help you. Okay.
Mm-hmm.
So it's really a laboratory experiment that correlates with a better immunologic response. It's just good information to know.
Absolutely, very interesting. And
Mhm.
on that topic of respiratory diseases, there was a small update from the CDC for their recommendations of flu vaccines for certain groups. Can you tell us about that update? And also, just what vaccine should we be looking out for this fall?
Yeah. So for respiratory illnesses to prevent, because respiratory illnesses can be so lethal, you have influenza, you have COVID, you have RSV, and you have pneumonia, bacterial pneumonia from streptococcus. So, and there's vaccines for all of those things. So there's an advisory committee for immunization practices, ACIP, that the CDC, our Centers for Disease Control in Atlanta, this independent committee advises the CDC, all these respected vaccine people and immunologists. And they make the formal recommendations. The CDC has to accept it. And so Dr. Mandy Cohen has accepted the group's recommendation, which has changed a few things. So what they added was if you've had an organ transplant, a kidney transplant, a liver transplant, a lung transplant, some kind of transplant, and you're between 18 and 64, they should receive the high dose flu vaccine as an off-label option. All right, so the vaccine is not going to say that the formal approval in the package insert is not going to say this, but the CDC is recommending it to go off-label. That's very common. They also, and that makes sense too, organ transplant patients have more immunodeficiency from the medicines they're taking to preserve the organ. And they unanimously voted for the new Merck vaccine, which I think we talked about last week. It's the new 21-valent pneumococcal vaccine. This is for bacterial infections. They recommended it for adults age 65 and older who have not received a pneumococcal vaccine or whose vaccination status is unknown. They also recommended a single dose in younger people, 19 to 64, who have certain underlying conditions who put them at risk. Those who received prior pneumococcal vaccines, but not all of them. And so this is just added to the armamentarium of what people can do to prevent getting sick with a severe respiratory infection. So that is in addition to the RSV vaccine, which we've also talked about, and the recommendations for that have changed. So 75 and up for everybody, and 60 to, I think it's 60 to 74 if you have underlying disease. And then also for women in third trimester can take this, and that will give the antibody to the baby and prevent them from getting disease, because those children, there's many tens of thousands end up in the hospital with RSV infection, very young babies under a year old.
And we will check back in on that aspect in a moment. But first, we're diving more specifically into the H5N1 avian flu. We touched briefly on another case last week, but can you tell us about it and explain potentially why the US cases we've seen thus far have been less severe than historical avian flu outbreaks?
Yeah, so there was a fourth human case, a dairy worker in Colorado. And so this adds to the case in Texas and two in Michigan. All of them did well. They tended to get a conjunctivitis type clinical picture. They've all done very well, and there's no evidence that this has transmitted human to human. It's all coming from the cattle to the humans, so that's good. Other countries are also reporting avian flu, including Cambodia, where 2 kids, a young boy 3 and a girl 5, tested positive after they came in contact with a dead chicken. The boy was hospitalized, but he is improving. The reason why we're so concerned about this is in prior outbreaks of avian flu between 2003 and 2009, a total of 468 infections in humans were reported. And this is worldwide. And 282, or 60%, died. So this mortality rate is potentially really huge. Now, we only have the 4 cases here, plus a couple here in Cambodia and other countries. The mortality rate seems to be doesn't seem to be 60%. So it could be that, we're recognizing it sooner, that, they're getting treated with anti-flu drugs like Tamiflu. We don't really know what's going on, but that is the whole fear of avian flu. If it mutates and starts transmitting human to human, it's got a 50% mortality rate, we're in trouble. So that's why so much attention is being played here. But so far, we don't have to worry. It's just animals to men and women, and we can deal with that a lot easier than if it's human-to-human transmission.
Mm-hmm. And I understand that other countries around the world haven't been seeing the cattle to human transition, but rather it's been focused on, as avian flu might suggest, bird to human transmission.
Right. No, exactly right.
All right. But switching back gears to that RSV story that you were mentioning with pregnant women, there was a great study that just came out related to that RSV vaccine and the chances of preterm birth, which, if you're getting vaccinated while pregnant or anything while you're pregnant, could always be a concern. Can you break down those findings?
So the Pfizer vaccine, Abrysvo, is the only RSV vaccine approved for pregnant women in the 3rd trimester, and that's to protect the baby. Because, like I said, 58 to 80,000 children a year get hospitalized, and many hundreds can die from it. So it's you can give the antibody Beyfortus to those babies, but they don't have enough antibody for all the kids, so it's sometimes difficult to get a hold of. But you can give the vaccine in the pregnancy. The vaccine is very easy to give, and it protects the baby, so it's terrific. Of course, people are always nervous about giving vaccines to pregnant women. And so this is a nice study from Cornell Medical College. And they looked at, how all these, this study cohort of almost 3,000 women who delivered between 2023 and 2024. And they found no evidence at all of preterm birth. So there didn't seem to be any complication with the pregnancies at all in this very, very large study. And so, and the neonatal outcomes were fine. So it's a safety report, and it's, prospective, done by a reputable group with a large number of people. And so people should feel confident that this is safe, because if you don't get it and the kid doesn't have the monoclonal antibody, it's going to lead to between 58 and 80,000 children per year hospitalized and hundreds of deaths.
Mm-hmm. If you are a pregnant woman, make sure you speak to your OB or your doctor about this, because there are the 2 different options on the market. Your delivery date may make sense for you to get one option or the other. So it's always great to have an open dialogue with your physician about those things. But moving on to our final story, an unfortunate one today. There have been a lot of discoveries of West Nile virus here in the United States, another mosquito-borne disease. Can you tell us about these infections?
So West Nile virus has been around for a long time, and the more you look for it, the more you find. There have been 15 cases in the U.S., in 11 states: Arizona, Arkansas, Kansas. Maryland, Michigan, Mississippi, Nebraska, North Dakota, Tennessee, and Texas. And more states have found it even just in the mosquitoes. And the issue with West Nile virus is that 80% of the people who have become infected don't have any symptoms or have very mild symptoms and don't know anything bad has happened. However, in the 20% that get symptoms, quite a few of them get neuroinvasive disease. They get encephalitis. They can be very sick, end up in the hospital, be disoriented, they have vision loss, paralysis, and in rare cases, people have died. So it's a very important disease to be on the lookout for, especially if somebody presents for treatment with some of those symptoms, those neurologic symptoms. At least they'll know what it is. There is no treatment for West Nile virus. And there had been a vaccine, but nobody wanted to take it because it's pretty rare. Even though a lot of people get West Nile, you know, not that many get sick. And then of the ones that get sick, about half of them get this neurologic complication. So anyway, the numbers may be increasing because of the expanded places where these mosquitoes can live due to global warming. We just have to be on the lookout for this. And it's just basically a notification of, you know, what to consider if somebody presents, you know, with some type of symptom like that.
Mm-hmm. And of note with what you said, while there have only been some 15 cases reported, half of those, nearly half, 7, have been neuroinvasive, as you described.
Right.
So there's ought to be a lot more asymptomatic cases out there.
Oh,
Just
many
wear
more.
your bug spray, people.
Yep,
There's
right.
mosquitoes everywhere carrying a lot of different stuff. So wear your
Mosquitoes
bug
like
spray.
us.
Mm-hmm.
That's right.
Alrighty. Well, on that note, thank you very much, Dr. Murphy, for your time and expertise, breaking down all the headlines and filling us in on all the new research. It's much appreciated.
Great. Have a
And
good
thank you
weekend.
all. Oh, thank you very much. And thank you all for joining us for another episode of the Ask Dr. Murphy series. Of course, if you have any questions or suggested topics, please leave them down in the comments below or contact us through any of our social media linked in the description. Have an excellent weekend.
Bye-bye.